Welcome to this episode of Orthodontics in Interview. It's my absolute pleasure to bring you guys Dr. Luis Carrière, the man behind the Carrière Motion Appliance, behind the SLX self-ligating brackets. It's my absolute pleasure to have this innovator come onto the podcast. So Luis, thank you very much for coming on to Orthodontics in Interview.
Now, thank you, Farooq, for you inviting me to your podcast. It's very interesting to be here with you and having a good time talking about orthodontics.
Thank you so much. So, guys, I want to give you a bit of background to Luis Carrière. So, he qualified from the University of Madrid, but he did his specialty training, his master's and PhD from the University of Barcelona. He's on the editorial review board for the AJODO. He's a contributing editor for the JCO. Of course, he's the innovator behind the Carrière Motion Appliance, Carrière 2, Carrière 3. We've already spoken about self-ligating brackets. Now, Louis has presented numerous times at the AAO, including over the past few years. He received the award for the Joseph E. Johnson Award with the AAO and is in private practice in Barcelona with the Carrière Orthodontics Center. So, really, Louis, it's great to have you here on the podcast. I've got so many questions about somebody who is an innovative of you, who's spoken as broadly as you have about orthodontics. My first question to you is, where did this idea of the Carrière Motion Appliance come from?
When I finished my orthodontic training, I started to work. My father is orthodontist, and we were working with a segmental technique, very nice, but it was working very well. So from there, I was thinking how I could come up with something that could help into the accomplishment of the class one occlusion on the posterior segment, moving everything in one block instead of moving single teeth to move segments of teeth in one movement and accomplishing a solid and consistent occlusion. Solid and consistent occlusion mean to accomplish a good rotation of the molars, good uprighting of the molars, and an adequate position. There is a beautiful article in the American Journal of Orthodontics that is done by Arnold Stoller in 1956, I think, or 54. And he explains very nicely the importance of the rotation and the position of the molars in order to have long-term stability for our cases. Also, there is a beautiful article that matches beautifully with the article of Dr. Stoller that is from Henry of 1954 or 56. Or both of them were on the same time. And this one studied thousands of malocclusions and came up with the interesting number of that the 83% of our cases, they have majorly rotated molars and majorly inclined molars, excessively majorly rotated molars and excessively majorly inclined molars. So these majorly rotated molars are pushing the case into class 2 because are occupying a space that belongs to premolars and canines, and they need this space to accomplish a solid and consistent occlusion in class 1, exhibiting a good intercuspation of premolars and canines in class 1. So I wanted to come up with an idea like that. So what I did an observation. Observation of what? Observation of the mother nature. Observation of what nature has created for movement. What is this? A bone, a long bone of the body, a femorous with a coxofemoral joint, also with some elements of an scapulohumeral joint. So I said, hey, this has been beautifully designed to give us a motion along life. The motion appliance, if you look carefully to it, is an imitation of the mother nature. It's a biomimetic design. So this is what we did. I did this appliance, this design in order to accomplish the expected targeted results that we wanted. That was to accomplish from a class one, from a class two scenario, accomplish a class one, moving the whole posterior segment, canines, premolars, and molars into a super class one at the beginning of the treatment.
What I wanted to ask you, Louis, was that the appliances really seems to have increased in its popularity over the past couple of years, and I want to know what your thoughts are as to why the appliance at this stage. I mean, its inception took place decades ago. Why, sort of, the past number of years, it's increased in its popularity, in your opinion?
Farooq, I started with appliance around 20 years ago. Okay. And I started lecturing. I went to a company called Class 1 Orthodontics because the owner was orthodontist and understood beautifully what was this about. No? Because and this is a disruptive element in terms of innovation. No? It's something totally different, disruptive, is new. So it's the message behind, especially at the beginning, it's a little bit more difficult to transmit and to make understand because it's a little bit disruptive. So he understood beautifully. He was Dr. Reynolds. He understood beautifully, and he decided to go and be and invest to be able to generate this or to fabricate this appliance for the orthodontic profession. Okay, so I started lecturing at the beginning in Texas. And I remember I was going there and I was flying from Barcelona and I was arriving there and I was lecturing for two people in the lecture area. So, and after
Wow.
swallowing two times, I was giving all of my my best to give these two people that was losing their time
Oh,
to be there to give them the most I could of this appliance. No,
yeah.
but something that happened since then is that everybody what was trying the appliance was completely adopting it immediately. And it was consistent, and it has been always consistent along the story of this appliance. So this is very interesting because, and this was something that was giving me personally the sensation that we were having here something that was useful for the doctors that were adopting it or using it because once they were trying it, they were saying, "Hey, I love this small thing." That's it.
I, and you mentioned this appliance as being a disruptive appliance. So, in comparison to similar class 2 correctors, we think about the conventional class 2 elastics, functional appliances, removable fixed class 2 correctors, Herbst, for example. Um, and where do you see the Carrière Motion appliance fitting in relative to those? Is it a version of? Is it something dissimilar to those and able to achieve beyond and what they can't? Where do you see it fitting in compared to those appliances?
The motion appliance is a story of simplicity. It's a story of simplicity, but simplicity does not mean simplicism. Means that is simple, is reducted in design, but deep in concept. It's a reduction in design, but deep in concept. So the motion appliance we have been working on. It's a very transversal appliance. Means that we can use the appliance in patients of early mixed dentition, 6 years and a half, up to patients of 65 years old that they have a class 2. And in all of them, we are going to accomplish the targeted, projected results according to what we pretend to correct. Okay. So it's an appliance that works at different levels. We know that the patient in orthodontics is not a set of teeth. We are claimed that the patient is a set of teeth by the companies that now are selling aligners directly to the patients. We arrange a set of teeth, but we know that it's not a set of teeth. We know that it's a set of teeth that is in a human being, and this human being has a face that has soft tissues, that these soft tissues, they do not have self-supportive soft tissue support, so they need the good position of the hard tissues behind to sculpture a nice facial outcome. At the same time, this patient has a temporomandibular joint, and this patient has elements, for instance, the airway. We'll talk later about that, but the airway and different elements that are everything connected in one unit. So everything that we work on the tooth, everything that we do on the tooth will have a impact on different areas because everything is connected and everything is in the same human being. Okay, so the motion appliance is an excellent tool for class 2 treatment and class 3 malocclusion. And in comparison with other appliances, I think is another approach to accomplish the targeted or the intended result in orthodontics. Okay, so McNamara, Professor McNamara, before starting to study the motion appliance, he wanted to come to see the office and wanted to come to see patients and to see what was going on into this appliance, to know if he wanted to know, if he was interested to go and study that, you know. And one of the surprises that he had is that in the office we were not using other functional appliances rather than the motion appliance, and was saying, "Oh, you are like an Amazonas tribe that is never touched by the human being," no? because we were facing the appliance with this appliance, the malocclusions, no?
That's interesting. So, do you see it as something which could phase out other types of functional appliances and class 2 correctors?
Everything is according to the diagnosis that you do and what you need to accomplish. If you want to accomplish a, a treatment in which so the question is that you need to prescribe the appliances according to what it is, what you need to. Everything that is not subject, for instance, you have a retrognatic mandible that is impossible to reposition it orthodontically, and you need surgery to sagittal advance, you will not use the motion appliance, for instance. Would be out of the target, because it would not be uh, adequate to use it in these particular cases, no?
Mhm.
But the broad spectra of malocclusions and conditions with retrognatic mandibles also, and with prognatic mandibles in class 3, that we can accomplish with the motion is a very interesting and very and very and quite broad.
It's very common to use the twin block appliance here in the UK.
Yes.
Would you say that, and it takes a similar approach to the Carrière Motion appliance in that it's sagittal first, it's correction of the AP first?
You
Do
know, functional appliances have been normally studied in the studies that has been carried out with the functional appliances. The main work, the main function that happens is dental velar, and the growth exhibited is very small. Is very small in all functional appliances. In fact, there is today a lack of evidence of permanent skeletal effect of functional appliances. So it's very interesting, because I think that we like to talk about growth, and the motion appliance is not an appliance to make people grow. No, it's not an appliance. It's an appliance in which what we pretend is a combination of effects. Is a combination of effects. One of them will be distalization of the posterior upper segments. If we talk about class 2, another one will be change of the occlusal plane. This is very important, the change of the occlusal plane, because when you change the occlusal plane, you change the width appraisal, and when you change the width appraisal, you change beautifully the relation between the nose, upper lip, lower lip, and chin. Also, we take advantage of the incorrect position that class 2 is manifested in the temporomandibular joint, because a big percentage of patients with class 2, they have an incorrect positioning of the condyle into the glenoid fossa, and the disc is shifted forward. This is very interesting, because there is an article from Gokal, which that they do is they observe the class 2 malocclusion and the class 3 malocclusion as well, but they observe the class 2 malocclusion, and they observe the class 2 malocclusion by MRIs. They do MRIs on each case of class 2 malocclusion. And what they see that the biggest amount of patients, there is a big amount of patients that they have the disc shifted forward, the posterior ligament is elongated, the condyle is sitting back and up into the incorrect position with the glenoid fossa. So this is something that from scratch is very common in class 2. Also is something that will help us into the reposition of the mandible into a better condition and a better position, okay? So basically, when we work in these different fields all at one time, we take a multifactorial outcome, and we arrive into the expected result that we pretend to arrive. So it's not a matter of growth, because when we see growths in the studies of 1 millimeter, 1.5 millimeters, I am not able to see a growth of 1.5 millimeters in a face. I'm not able. And you neither. Nobody's able to see 1.5 millimeters growth anywhere. So it's a matter that that we can really squeeze every element that is exhibited in a malocclusion and try to help into establishing a correct relation, a correct functional occlusion, and a correct adequate position for the years to come. And of course, stability for the years to come. And where it comes, the stability? To the good occlusion that we accomplish. If we accomplish a good posterior occlusion, a good matching occlusion in class 1, we will have stability for the years to come. Today, one of my lectures that I am giving at most is long-term stability in class 2 malocclusion, because I have cases over 16 years follow-up that started with retruded mandibles, finished with a beautiful occlusion in an adequate relation between the nose, upper lip, lower lip, and chin. And after 16 years, even I have one of 19 years follow-up, because in this 19 years follow-up, I started with a gold one done by hand, because I did before having any appliance, I did some of them in solid gold with a process of manual manufacturing.
It really maps itself well to what is claimed from, or what is evidenced when it comes to functional appliances. But one of the things that you mentioned there was also about changes to the TMJ, and I think that's always been an area of controversy when we look at some of the
Yes.
larger systematic reviews from Luther and Kim, and essentially stating that orthodontics is unlikely to affect one TMD, but also long-term wise, it becomes very difficult to find studies which show permanent changes taking place to the position of the condyle. Now, what would you say to people who suggest that actually that's something which is postural and something which isn't?
Yeah,
And
you
I
know,
want to get.
one of the Farooq, one of the elements that made me point out the interest in the temporomandibular joint was a consistent release of several patients at the beginning that I was treating in class 2, that they were having temporomandibular pain or clicking. And after the accomplishment of the class 1 platform, this was disappearing. So this highlighted my interest for what was going on. Okay, so after that, consistently, we have been approaching the many cases today in the office with the motion appliance, and with a quite high level of consistency in terms of the release of the temporomandibular pain and clicking when they have a sagittal problem of class 2, and some of them when they have a sagittal problem of class 3. Okay, so why is that? Well, we see the studies of Gokal on the MRIs and the disc. Okay, very interesting. But they tell us that the disc is in a wrong position. Okay, when we hear a click on when we have a pain and clicking of the temporomandibular joint, we know that there is something in an incorrect position. And when there is a click, we know that the disc is shifted forward, because there is a recapture of the disc when the patient opens the mouth. Okay, so what we pretend with the motion appliance is to change the occlusal plane. In class 2, we change the occlusal plane clockwise. In class 3, we change the occlusal plane counterclockwise. But this change of the occlusal plane drives into the help of distracting slightly the condyle from the deepest part of the fossa. By distracting the condyle from the deepest part of the fossa, we release space for a spontaneous reposition of the condyle of the disc into the correct position. But what happens? That the temporomandibular joint it has a multifactorial possibility of having a disorder. It does not completely belong to the orthodontic specialty. Can be that the patient can have a superelasticity of the ligaments. Maybe the posterior ligament of the disc, even though that we distract the condyle from the deepest part of the fossa, maybe this hyperelasticity of the posterior ligament of the disc drives into an incapacity of repositioning or recapturing the disc back into the correct position because the ligament is not efficient enough. Then we would not be solving in this particular case the problem of the temporomandibular joint. Or might happen that the not particular patient can have a glenoid fossa that is not adequate in form or anatomical element that exhibits an impossibility of having a correct function on the joint. Maybe, but this does not belong to us. But one of the things that to me is super concerning, is to see a patient in class 1 with pain and clicking. Because we know that if the patient is in class 1, the patient is stopped forever into having any possibility of having or extending an invitation to the condyle to sit in an adequate position. When I see a patient having pain and clicking in class 2, or even having pain and clicking in class 3, at least as there is a sagittal discrepancy, I know that there is a possibility of helping to this patient to have a better scenario into the function and the symptomatology of the joint. But
So,
what happens? This is once again is innovation, and innovation needs to generate studies on that. And normally, when I lecture in universities, I always tell to the students or to the PhD residents and tell, hey, this is a fantastic area to investigate because has not no studies on that yet. I have seen it on my study of life that is the clinic, that is a scenario where you work in a daily basis since 20 years ago with many patients and where there is a consistency in what happens. But we need to have studies on that.
no problem. So, Lou, if I was to just rephrase part of that question and say, if a patient came in to see you with a sagittal discrepancy in the class 2, would you have confidence in the Carrière Motion Appliance or any functional appliance which is able to release the condyle in managing their TMD, or would you consider it as a bonus as well as correcting sagittal? Would you use this as a curative
Farooq,
approach?
if when a patient, I will tell you, when a patient has a class 2 malocclusion arriving to an office, in our office, with pain and clicking, and even limitation of the opening if that something happens, I am confident that we can help. And I tell the patient, we might be able to help you. And I cannot promise it because it's multifactorial, but according to your malocclusion, to what it happens to you, there is possibilities and quite interesting possibilities of releasing the problem of your temporomandibular problem at the end of the motion stage, not at the end of treatment. After 3-4 months of treatment, you will see that this happens. If this happens, this will happen then. This will happen then. Then we will maintain this occlusion and finish the case into
Mhm,
the correct relation. Okay,
mhm.
so I am confident on the motion appliance. I am not confident in other devices because functional devices are completely different in biomechanics. Everyone is doing different aspect. A herbs appliance is pulling forward the mandible and strongly pulling forward the mandible. The motion appliance is not pulling forward the mandible, it's changing the occlusal plane. It's like extending an invitation for repositioning into the adequate relation, the position of the mandible in relation with the maxilla, and additionally is working in other areas on rotation of the molars, on distalization, change of the occlusal plane, and reposition of the mandible by distracting helping into this distraction of the condyle into the correct position, etc., etc. But one thing quickly. But what happens in this percentage of patients that they have a correct position of the condyle and they don't have a sagittal discrepancy. And they have a sagittal discrepancy. What happens? There are some of the patients, percentage of patients, that they don't have an incorrect position of the condyle. So what happens? That we don't see any change of the position of the mandible. It's completely exhibited, rotation, distalization, but there is not repositioning of this mandible into a sagittal better condition.
And you spoke about, just picking up on 2 points there. The first was you mentioned about the mechanics of different functional appliances, Herbst and Twimblock could be argued is different to that. But in comparison to, say, just using class 2 elastics and the conventional fixed appliances, would I be right in saying the difference between that and the Carrière Motion Appliance is just the simplicity of the
Very
Carrière?
good question. Very good question. Very good question. You see, this is a chain. It's a chain. A chain. I take this chain and I hold it like this. Let me say, hold it like this, right? This is what architect Gaudí, you know Gaudí? There is an architect that is very famous, that is Antoni Gaudí, that did the Sagrada Familia and was a super architect, biomimetic art. He took a chain and took this chain, hold it by both ends, and found it that this was the catenary arch. You say, what the heck is that, the catenary arch? Okay, he said, okay, let's do. I will place it upside down. He upside it down and constructed the catenary arch. This catenary arch was able to hold super high structures in architecture and was able to hold with super aerial insight in the building. Means did not need any reinforcement anywhere because everything was super stable holding this. Okay, what we do as orthodontists, we place brackets and we connect the full brackets with the wire. We do a catenary arch. So we place elastics. And what do they do with elastics? They work on the posterior segments of the wire, right? But what happens? This anterior part does a reaction opposite to the action of the elastics. And this is basic physics. Basic. This is the reason why an egg is so thin and we are unable to break it. Why are we unable? Because the curvature of the surface of the egg minimizes the stress, dissipates the stress super efficiently. So what we do with the motion appliance? We segment the arch. We forget about the incisors. Incisors are not invited. So we only work on the posterior segments. Disconnect left and right. Totally different treatments left and right. The left one can have different action, different force than the right one according to the needs of each side. So by not having any reaction of the anterior part, this completely is like a rocket to correct it.
I hear it. I hear your difference there in separating what is ultimately the Carrière Motion Appliance segmental mechanics from what is continuous mechanics and the other appliances out there. That's interesting, and thank you for
Correct.
clarifying that. You mentioned about research and picking that topic up, is that, as far as I'm aware, there's only been one real trial when it's come to looking at things prospectively when it comes to the Carrière Motion Appliance. Now, the appliance has been around for some time, and you mentioned how you've spoken about it on your lectures and invited people from different academic backgrounds. But at this point in time, we really haven't got much when it comes to substantial studies in the Carrière Motion Appliance with good methodologies. Why do you think
Mhm.
that that is the case? Why have we not managed to get to that stage in our evidence-based practice in orthodontics?
In orthodontics, many authors inventing something, they publish their studies on the appliance. Uh, I hate that. I don't want to publish studies on my appliance. I don't want, because I am not the person to talk about the action of the appliance. I want third parties to talk about it. I did my PhD thesis on 60 consecutive cases on the motion appliance. Okay? So I know what it does, but I did not publish it because I don't think that an author or an inventor has to publish data on their own invention. So what happens? Well, what I do, if there is a researcher that contacts me, I want this material. Can you provide me material? Yes, I provide material. Dr. McNamara, for instance, came to me. Can you provide me material? Can we go in your files and can see what we need? Pam pam. Yes, you can. You do it. You investigate. Many authors have been telling me, "Hey, Luis, you want to be in the study?" And no, never, because this will totally lose the magics, you know. So the studies has to be done by the community, and the community they have to come up with the experiences. You are talking about innovation. This is an appliance that probably is the youngest in the profession. Is the youngest. So we are comparing with an appliance of 1904. Okay, so Albert Einstein, there is a very interesting element of Albert Einstein saying that it was in the letters to Solovin in 1951. And he said, if you want to improve with different results, don't continue doing still the same. So at the end, we need to wait for the researchers to every academic or clinician to make their studies, to make their work. And I don't want to be involved on studies, you know. I know what it does, but I want to read it and listen it from others.
Somebody else's turn. Um, and I want to touch on one final kind of technical point of the Carrière Motion Appliance and some of the statements that have been made in relation to it being specifically from the Hemishine website and your lectures is this concept of airway friendly orthodontics. Now, it's something again which has some controversy to it, as where does orthodontics stand when it comes to managing airways of patients who have either breathing or sleep disorders when it comes to the airway? Where do you see our field developing in that respect? Because that's also probably a newer science when it comes to interactions with orthodontics.
There are some studies on the airway. ATIA did a beautiful study of three-dimensional CBCT evaluation of the airway changes of the treatment using the Carrière Motion Appliance. It was in the Journal of Dental Science and Maxillofacial Research. It was in 2012. And well, it was very interesting in terms that resulted in the treatment with the motion appliance resulted in an increase of the total pharyngeal area, airway area, and the minimum cross-sectional area as well. No, but on top of that, it's a matter of understanding. When we have a patient snoring, what do? We do an appliance that many times projects the mandible forward, right? With like a kind of herbs appliance that projects the mandible forward for sleep, and this opens the airway of the patient and improves the airway of the patient. Now, again, airway is exactly the same than TMJ. It's multifactorial. If you have obesity, if you have anatomical elements in your pharyngeal area, if you have hypertonicity or hypotonicity of the musculature around this area. Those are elements that we cannot change. We cannot change. But we know that we have a genioglossus, we have a genioid ioid, we have a mylohyoid, that we have a digastric muscle, and we know that all those muscles that belongs to the base of the tongue, those muscles, if we change the reposture of the mandible of the mandible in a better condition, we will exhibit a better decompression of the uh, posterior third of the pharyngeal area, where the functional airway is where the functional airway is. So we have seen that has been an improvement of the airway capacity of many patients by the change of the sagittal phase of the mandible on this relation. Of course, more studies has to come. Of course, studies like I'm wishing to be reading on temporomandibular disorders using the motion appliance. I would love to read articles like those. And the question comes here. Now, if we have a percentage of improvement that is related to orthodontics, shall we deny it to the patient? Is correct to deny that to the patient because we are not in a full 100% of capacity of correcting the 100% of the airway? Or can we try to give the best we can to our patient to improve their life and to accomplish a better result if we can?
I think it's an interesting topic within orthodontics and generally just in respect to healthcare. I think one of the challenges that we have with this is that, and you're absolutely right, there are studies that support the changes in volumetric changes with the airway with different appliances, whether it's going to be the Carrière Motion Appliance or whether it's a functional appliance or different types of appliances. But I suppose the challenge comes is that we still haven't got the evidence that the end outcome, does it actually change their disorder, disease quantity with respect to that? And there was the paper, the white paper from the AAO published a few years ago by Barahantz, and essentially describing how early we still are in understanding these relationships, and where orthodontics then fits into it at that point in time. And that was a couple of years ago, and some studies have come out since then. But it's still an area where volumetric changes, as far as I've understood it, don't necessarily correlate to disease change. And as you mentioned, it is a multifactorial condition where actually we're still not 100% sure what is the etiology without having these investigations. But it's interesting you view it as it's an option. It could happen. It can happen. It has the theory to happen. We're still waiting for the evidence to prove that. Um,
Yeah.
yes. Did you have any more thoughts on the airway?
Well, at the end of this is this, no? We have the capacity of changing the relation between the maxilla and the mandible in a patient of class 2, even if it is an adult patient that is non-growing, because big changes, we can do big changes on the positioning of the mandible relation with long-term stability. And by bringing the mandible in a better sagittal condition, we are going to bring all the musculature that is related to the base of the tongue, and we will bring everything forward, and this will decompress the posterior third of the pharyngeal area. And now, if this is going to solve the airway of the patient at the 100%, maybe yes, maybe no in a big percentage, maybe zero in another patient. But this means that we need to restrict our treatment because we don't have the full capacity of correction of the airway. Absolutely not, because medicine is a multifactorial specialty and needs different professionals to solve different pathologies. And the same happens in dentistry. Dentistry needs different pathologies, different professionals to solve different elements. And in some of them can be a conjunction of the orthodontic work together with the professionals that are related to other areas on the medical side.
And it shows very much that you are on the entrepreneurial side, where there are potentials and possibilities. You're very much exploring those. And I just wanted to kind of ask a question actually away now from the Carrière Motion Appliance, which has been the main of this podcast. But as an innovator, it's not just a Carrière Motion Appliance, it's self-ligating appliances you've been involved with. I'm interested to know as to what you see our field developing as you're a clinician. What do you think the next thing is going to be within orthodontics that moves our field forward? What's next?
Well, I think that we are going to go to efficiency. Efficiency. Today, in we need to accomplish our treatments in a shorter treatment time as we can and as less number of appointments as we can. So we need to define perfectly our strategies from the beginning to the end in order to be able to decrease the number of appointments of the patient in the office. This patient coming 20 times into the office for a treatment or 20 something times to the office will belong, in my opinion, will belong to the past. And probably we will hit we will treat the cases in an average of time, always depending on different scenarios that we all know that happens in orthodontics, but in an average of 5 appointments, real appointments in front of us, physical appointments. Other ones will be digital appointments, appointments in which we will have an eye on the patient. We will request the patient to do certain actions on the treatment in the distance and will help us into finishing the treatments with predictability, very important, accomplishing promises that we have done to the patient, that this is the most important thing today. And secondly, solving what patients are looking for: efficiency, short period of time, less number of appointments. And very importantly, highlighting to the profession, the importance of all the elements that we can have an influence, that are the facial. I think, in my opinion, the orthodontist is the number one professional in the world of facial aesthetics. Facial aesthetics? Yes, because we are the only ones that we can manage the position of the hard tissues and the relation in between the bones in order to establish and accomplish natural beauty. Because natural beauty is not the same than beauty. Beauty of injection of fillers of this is beauty, but it's not natural. We can see it from miles. But natural beauty is accomplished by managing with an orthodontic treatment, for instance, and accomplishing a nice curvature of the upper lip, a nice supramentallus curvature, a nice relation between the nose, upper lip, lower lip, and chin, a beautiful expression of the soft tissues, an improvement of the nasolabial growth, a diminishment of the marionette lines. Those elements that if you properly manage the hard tissues, you will accomplish beautiful finishing of the cases.
To conclude the interview, Louis, it's been fantastic talking to you. But what I want to know is, what one piece of advice would you want to give to the orthodontists out there who are listening?
I would advise to the every orthodontist that is coming out today is to, because now is the time of aligners, now is the time of clean checks, and time is the time of seeing a set of tooth and moving the tooth and solving it in virtual reality and arriving some plastic materials to solve it, which is fantastic. But telling them that the patient is a human being. Is a human being in which is having a face that wants to have the best facial outcome we can. Is a patient that needs to have a functional occlusion in order to have a good health in terms of temporomandibular function. Is a patient that needs to have an adequate position of the structures in order to have prevention of good health along the years to come, with gum health, with bone health, with good occlusion and stability of the elements, and is a patient that is a complex element in which we need to care of their happiness in life. We can produce beautiful results of facial outcomes, but we can produce terrible results of facial outcomes and ruin the life of a patient, because we are, in our hands, is the most contemplated foot square of the earth, which is the face. So this is super sensitive, and we have to be very respectful with this, because as if every patient was our own kid, That would be my advice.
Wonderful. Thank you, Lou, for this for attending for this interview. To the listeners out there, please do subscribe and look forward to our next episode.
It's a pleasure, my friend Farooq. It has been a fantastic interview. You are a fantastic driver of good questions. You challenge beautifully, and I like that. I like that. Right?
Cool. Thank you so much.